Well, welcome back. This week we are going to be covering topics of both pediatric ethics and the other end of life, geriatric ethics. Let's start with pediatric ethics. You know, the interesting thing about pediatric ethics, or certainly one of the interesting things, is just the nature of the relationship between a clinician and the patient. It's always kind of a tripartite relationship, because you have the parent in there, the parent or the guardian. So you know, and that can make for some very interesting situations, as we'll see later on. In some cases, the parent or the guardian may not be making decisions in the best interest of the child, and you know, you may have to decide, you know, what steps are appropriate in order to address that. You know, in general, anytime you have essentially a surrogate decision maker, because that's what we have, the child is by law considered incompetent, as we'll see, you know, it leaves open for a lot of potential risk. The other interesting thing about the pediatrics relationships is that they are fiduciary in a way, you know, even beyond the way in which a normal professional relationship is fiduciary. Fiduciary simply means trust-based, as we've noted before. A client or a patient has a fiduciary, you know, is in a fiduciary relationship with the clinician, in that the clinician has a higher level of responsibility in the relationship. The patient or the patient/client in the professional relationship in many ways can only trust that the clinician is using her or his skill and knowledge in their best interest. So fiduciary just simply means trust-based, and professional relationships are said to be fiduciary primarily because the receiver of the service is in a position such that they can only trust that the professional is using their skill and knowledge in a responsible manner, because they really wouldn't know otherwise. Now, this is especially the case, you know, in pediatric ethics, because a child is even more vulnerable than an adult who might be able to, you know, fully competent, informed adult. A child is more vulnerable. I mean, they're dependent upon the parent, who may or may not be making the best decisions in their best interest, and you know, so it requires a significant level of trust in these sorts of relationships. Unless a person is 18 years of age or older and incompetent, they will almost always have a surrogate decision maker, someone there making decisions on their behalf. And that is certainly the norm in pediatric ethics. When you have kids, someone's making the treatment decisions, and it's usually typically, you know, not the child, although we'll look at some possible exceptions. You know, anytime a decision is made in a pediatric situation, a guardian or a parent is making the decision on behalf of that child. There are a range of standards by which surrogate decisions are made. That is, when you have an incompetent patient, then we have to figure out who's going to make decisions for that patient, and according to what standard are they going to make those decisions. Now, some of these traditional standards for making decisions for incompetent patients don't necessarily apply in a pediatric situation. Certainly, children don't have advance directives, because in order to have an advance directive, you have to be, in the eyes of the law, competent, and children, according to legal definitions, are not competent, although, as you and I know, it's certainly possible that they could have adequate decision-making capacity. The next sort of standard that's appealed to is what's called the substituted judgment standard. According to a substituted judgment standard, a surrogate decision maker should make the decision that they think the patient, him or herself, would have made, based upon the surrogate decision maker's knowledge of the patient's values, preferences, and so forth. This too is a little difficult because, obviously children, frequently do not have decision-making capacity, so we really don't know what their informed, competent preferences were in order to make decisions on that basis. Although, it certainly is possible to make decisions on behalf of a child that you think both would be in the child's best interest and that are consonant with the child's wishes in a way that is safest for the child. Typically, the predominant standard for making decisions for children is this third one, the best interest standard. The best interest standard applies when a patient is not competent to make decisions for themselves, which, captures most kids. Then the guardian/parent simply makes the medical decision that is in the child's best interest. Best interest holistically speaking, not just simply in terms of a medical interest, but the surrogate decision maker is not typically trying to guess, what sort of decision would be most consistent with the values of the patient. That would be the substituted judgment standard. So most pediatric decisions are made according to a best interest standard. Now, why do we use things like advanced directives and substituted judgment standards? Well, usually those things come into play when you have a formerly competent patient who's no longer capable of making decisions. We make decisions based on what we think they would have chosen. So that's all for the sake of autonomy. But we say that by and large, children compared to adults, are substantially less autonomous. So what does that, the normal reason for providing information to patients is in the service of their autonomy. We've gone through the whole informed consent thing, and it is in the service of the respect for patient autonomy that we provide information so that the patient can make an informed decision according to his or her own values, and that's what it is. It's done as a way to respect patient autonomy. Now, it sometimes happens, though, that we withhold information from children. The question is, when is that appropriate? When might that not be appropriate? Well, first of all, I should note that parents often request that information be withheld from their child, especially if they believe that that information is going to be emotionally harmful to their child. Let's say you can imagine the parents of a terminally ill child not wanting the the healthcare team to disclose the nature of the child's diagnosis or prognosis. However, I think we would be mistaken to believe that children lack autonomy completely. It's not as though a child has no decision-making capacity whatsoever. Most of us are kind of on a continuum. We're more or less autonomous, but not entirely autonomous. And the same goes for children. When determining whether to withhold information from a child, we have to take into consideration the maturity of the child and the child's decision-making capacity. If it's a very small child, they're not going to understand the information. If there's no real substantial autonomy to respect, then there's no real reason to burden a child with information that they can't process or put into context. However, when a child does have decision-making capacity and has in your mind requisite maturity to understand and appreciate and make a decision, then there should be a presumption in favor of providing that information to a child. And when you meet with resistance, when the parents are resistant to the plan to discuss a child's medical treatment openly with the child, there's no easy way to navigate your way through that other than to discuss with the parents the purpose of being open and honest and disclosing treatment options and with children. It's not simply in order to respect the autonomy that they may have, and respecting their dignity as persons, but it also makes for a much more successful treatment plan and less anxiety-ridden for the child, that they know what's going to happen and why things are happening and what, So the general rule of thumb should be, to the extent that the child can understand, the child should be a participant in treatment decisions. There are just some practical reasons why keeping secrets from sick children can be a bad idea. First of all, it's difficult to maintain these secrets. Think of how many different moving parts are going on in a particular hospital or in the treatment of a particular child. Different kinds of specialists come in. Nurses come on shift and they go off shift. It's very difficult to maintain a lie or to withhold the truth when you have that many players involved. And sooner or later, someone's going to slip. Moreover, kids are smart. They can pick up when people are avoiding their questions or giving very sort of vague answers, and in many cases, it only produces a greater level of anxiety on the part of the child. When they have the sense that there's something about the nature of their illness or their treatment that they're not allowed to know, in many cases it only makes them more anxious, and less able to throw themselves into their treatment plan. What about refusals of treatment? Can a child refuse treatment? Can a parent refuse treatment for a child? Well, of course, I mean, in many cases, it would depend upon the circumstances. Oftentimes, we think of, life-prolonging treatment that would potentially prolong a child's life, but the parent or the child would refuse it. Just for the sake of focusing our discussion right here, let's think in terms of life-prolonging treatments and those sorts of things. Can a child refuse treatment? Well, I mean, as you would probably guess, well, it depends. It would depend on the maturity of the child and the situation in which a child would be refusing treatment. Certainly, we want to take into consideration the wishes of the child and the child's decision-making capacity. If the child has adequate decision-making capacity, knows what they want, understands everything adequately, then normally we say a patient should be able to act according to their own wishes. Now, oftentimes it might be, those wishes might be in conflict with the wishes of the parent, but those conversations just have to be worked out. If a very mature, competent child is making a very reasonable decision to refuse a treatment that, for example, in your mind, would be burdensome and offer only marginal benefit, there might be a strong presumption in favor of supporting the child's decision. If the child is making a decision that in your mind is against the wishes of the parent and clearly at odds with what you would take to be the child's best interest, then you would have good reason to simply comply with the wishes of the parents. Of course, in doing that, it's not as though you cut the child out of the conversation, but rather make every attempt to explain to the child why simply following their wishes or accommodating their requests may not be possible under the circumstances. What about refusal by a parent? I mean, every now and again we will see a case in the news where a parent refuses a life-saving procedure for a child. Usually these are cases where the court just simply steps in and mandates the child into treatment, and rightly so. Ordinarily, under normal circumstances, a parent or a guardian, can't refuse, what life-saving treatment or a treatment that is clearly beneficial to their child. Think of these cases where a parent, where a child has a kind of, let's say, a form of blood cancer, and that might be very successfully treated with chemotherapy, but the parent refuses chemotherapy and would opts for some sort of alternative complementary medicine approach or something like that. Usually, the parent's wishes are overridden because we can't allow a child to be harmed by a bad decision of an adult, even if that adult is their parent, who typically would have decision-making authority. Oftentimes, the you know, the refusal by the parent may be contrary to the wishes of the child, or the child, you know, taking into consideration the child's preferences and values. Certainly, if a child if a child is willing to undergo a therapy that you think is medically appropriate, and in your mind, you know, offers a reasonable hope of benefit, then that would count as a powerful reason to override the refusal of a parent. I think the refusal by a parent to offer life-prolonging treatment or life-saving treatment is most persuasive when the benefits of that treatment are in question or marginal. That's when we are most, you know, most prepared to allow a parent to refuse treatment for their child. Now, I say this knowing full well that parents, you know, make 99% of all their children's treatment decisions, you know, from, you know, whether to get allergy shots or you know, any sort of mundane sort of primary care issue. I guess what I'm focusing on here are these very sort of difficult issues when parents are either refusing life-prolonging treatment for their child, or the child themselves might be refusing life-prolonging treatment. There are a number of very famous cases that speak to a rationale for overriding parental refusal of treatment. In these cases, the ones discussed in our pediatric ethics cases, or pediatric ethics chapters, of which there are 2. These cases center around primarily around cognitive handicaps, but in any case, they center around cases whereby the cause of death or the rationale for withholding treatment is not related to the potential benefit of the treatment, but rather related to the handicap or the likely handicap of the unborn child or the newborn child. The classic examples are the baby doe sorts of cases in which a parent may be permitted to withhold a life-prolonging treatment simply because the baby in question has, for example, Down syndrome. That in fact, it was the baby doe case. This was a Down syndrome infant with an esophageal blockage and correctable, you know, surgically correctable, but yet the parents withheld consent to do the surgery, and in fact the baby died. It was that case that led to some amendments to the Child Abuse Prevention and Treatment Act, CAPTA, that now place restrictions on the extent to which a parent can refuse or withhold or withdraw treatment when their infant is simply affected by a cognitive impairment or some other sort of related disability. I guess the thinking is that it's one thing to withhold or withdraw treatment because it's simply going to be burdensome to the child to no good end. But in these baby doe cases, it seems like what the courts object to and what the moral problem is, it seems like we're making a value judgment about the life of a Down syndrome person, that their life would not be worth saving, and that's what this is really all about. Now, there's someone might try to make a quality of life judgment that, well, if we save this child, what sort of quality of life will they have? Well, clearly, certainly a child with Down syndrome could have an excellent quality of life. It may not be so clear in other kinds of other sorts of handicaps. Certainly the case of baby Jane Doe, Carrie Lynn, was a little more complicated, but those are difficult decisions that the clinicians have to work out with parents, pulling into play, how burdensome these treatments are going to be, and what sort of life the child is going to face. But one thing is clear: the mere fact of having a cognitive impairment, being cognitively disabled, says nothing about the value of that life. And in fact, certainly in theological circles and religiously sponsored hospitals, there may be an extra vigilant emphasis on protecting the lives of those especially vulnerable infants, where parents may feel overwhelmed and may feel that the surgeries following the birth of a handicapped child, may be extraordinary care and something that they could morally forego. All right. Now, as I mentioned before, when we talk about autonomy, it's on a continuum. It's really all or nothing. By and large, adolescents have less decision-making capacity than mature adults for reasons that might be obvious. And more mature, you have more experience, and but adolescents almost certainly have greater decision-making capacity than young children. So the more autonomy a person has, the more control they should have over their treatment options and the choices that they're allowed to make. Of course, adolescents are, adolescents younger than 18 are considered legally incompetent. But as we discussed earlier this term, decision-making capacity is usually relative to the complexity of a decision. That is, whether or not an adolescent counts as competent, at least in the moral sense, has only to do with whether they have decision-making capacity that is equal to the decision that has to be made. And we can think of a whole host of decisions that may be relatively uncomplicated, that a child can make. And we could probably think of many adolescents that are very mature, and they have considerable decision-making capacity, and therefore they should be considered competent to make treatment decisions. That doesn't mean that we shouldn't exercise significant caution when allowing adolescents to make decisions, or maybe to put it better, when including adolescents in treatment decisions. Although they may have a high level of cognitive capacity, more so than, say a 60-year-old or 68-year-old retired, ophthalmologist, they may have superb cognitive capacity, perhaps doing levels of math that you and I could only dream of. Nonetheless, there still could be a range of factors that significantly diminish their decision-making capacity. One such factor might simply be not cognitive, but emotional, that is, affective. The competence is not simply a matter of cognitive ability, although when we do psych consults, it's often focused on what you know, what you can remember, and those sorts of things. But to be able to make to be considered competent to make treatment decisions, it's also important to have the right sort of emotional, a level. You have to have a certain level of emotional health and appropriateness to be competent to make a decision. And while a teen may be cognitively very very capable, they may emotionally not be. Now you could say, well, geez, that could apply to anybody. Yeah, but certainly, teenage years are years of transition, and there's certainly a complicated emotional dimension to all of that. So clinicians have to be aware that very bright children still may lack competence because of perhaps emotional maturity. There's also the point of lack of moral self-government. What is moral self-government? Well, we all have kind of a sense of who we are, what our core values are, what we care most about in life, and it didn't come overnight. It's the older you get, the clearer it gets for you. You have a self that becomes kind of stable and predictable, such that when someone says to you, "Geez, that was out of character," we know what they mean. But that's because you have a stable formed character, and you have self-government. But kids, adolescents in particular, are kind of a work in progress. They're trying on different selves, and maybe into this one day and not into that another day. It would be very difficult for an adolescent to look 10, 15 years down the road and be able to say what he or she is going to care about at that stage. by contrast, I think a 35-year-old could say, yeah, you know, I think when I'm 45, I'll change a little bit, but I think I'm going to probably still have these stable sorts of values, beliefs, and preferences that more or less define me. Certainly in a way much more stable and predictable than that of an adolescent. So for that reason, you know, adolescents may lack decision-making capacity / autonomy in a way that you and I don't. And then finally, before I move on, of course, you know, most of us know that there may be certain circumstances, you know, under the law when adolescents are permitted to make treatment decisions. You know, the most notably have to do with reproductive services and things like that. You know, to get treated for an STD or something like that. The law typically doesn't require parental consent. I guess the thinking is if we required parents to give consent, kids would never seek treatment because they don't want their parents to know, you know. So in that way, it's kind of a utilitarian, consequentialist thing. We should be aware, though, that state law differs. You know, so you know, you should be aware of kind of what the health law is in a particular state regarding adolescents and their ability to consent or withhold consent, specifically regarding these sorts of reproductive and sexual related treatments. Abortion, for example, you know, there's much more restriction on that. Many states require, as you can imagine why, parental consent, or in some states at least parental notification. We've got a little chart in our book, but that's because, you know, the more serious a condition is, and the more likely it's going to require considerable follow-up visits, it's almost certainly going to be important to include the parent in the disclosure of information. And I guess that speaks to this concept of trust and privacy and confidentiality. You know, I mean, why do we care about privacy and confidentiality in general? Well, of course, we ensure confidentiality to patients so they can typically so that they can feel free to speak openly and honestly. I mean, the therapeutic relationship can't function without the cloak of privacy, without the promise of confidentiality. If patients believe that information is not going to be kept in confidence, it will have a chilling effect on the kind of information that they would be willing to disclose to the clinician. And this is especially the case for adolescents that tend to be quite a bit concerned about their privacy and what people think of them, and, you know, very concerned about sensitive information. Now, like I said, that's not unique to adolescents, but it certainly is something that is notable about them. So, and this is not mere speculation. I mean, studies have shown that, you know, if information about treatment for, say, sexually transmitted diseases is breached, if confidentiality is breached regarding those matters, studies clearly show that kids are going to be much less likely to seek treatment, especially from those particular facilities where they think that confidentiality is not going to be maintained. So that's not just mere speculation. You know, there's hard empirical evidence to suggest that, you know, teens aren't going to seek treatment if they think their privacy is not going to be respected. Now, that wouldn't have to be restricted to simply reproductive sorts of things, but certainly those are the ones that kind of get the most, moral examination. Now, like we said, there are certainly important limits to a child's maturity, and which translate into limits to their autonomy, which of course translates into limits to their decision-making capacity. But even in general, confidentiality serves an important role in protecting the flow, the open flow of information in the therapeutic relationship. But confidentiality is not an absolute promise. There are limits to confidentiality. Oftentimes we may have to breach confidentiality to protect innocent parties, either to protect the patient, him or herself, or to protect some outside party from risk of harm. These famous duty to warn cases. Many people are aware of the famous Tatiana Tarasov case, which really was kind of the landmark case to produce these duty to warn norms. A duty to warn case is a case whereby the patient has disclosed some piece of information that suggests that an outside party is at risk of harm, and in order to prevent that harm, confidentiality must be breached. In the Tarasov case, Tatiana Tarasov was an undergraduate at Berkeley, UCal Berkeley, and this was in the late 60s, and her boyfriend had confessed to the campus therapist that he was having fantasies about killing her, and she went on vacation, but when she came back, sure enough, he killed her. That information never really made it to Tatiana Tarasov or anyone that could really do anything to prevent him from causing harm to her. Ever since then, we've had a series of kind of laws and legislative revisions regarding duty to warn, and it now kind of highlights the limits of confidentiality. Now, of course, in these cases with adolescents, we're typically not necessarily talking about instances of breaching confidentiality to protect an outside party, but it's usually we're breaching confidentiality in order to protect the child, him or herself, precisely because we recognize that as adolescents, maybe mature adolescents, they still don't have enough autonomy, enough decision-making capacity to be able to do this alone. Therefore, we feel that we are justified in breaching confidentiality and informing parents so that there's another party there looking out and looking after the patient adolescent. That said, it's always important to establish the limits of confidentiality at the outset of any relationship. So the adolescent patient should know that while confidentiality is expected and they can speak openly and honestly, they have to also know that there are some circumstances under which you, the clinician, will be obligated to breach confidentiality, typically to protect them or someone else. if you take the time to establish those limits and disclose those limits to the patient at the outset of the therapeutic relationship, then when you disclose what would otherwise be confidential information, that disclosure, that breach, is not viewed as a betrayal of trust, but you're simply following through on something you said you were going to do. So the therapeutic relationship may very well, be able to continue even though you've breached confidentiality. If the breach of confidentiality comes out of the blue, when the patient had no, had no idea that you could potentially breach confidentiality, then the breach of confidentiality may be viewed as a betrayal of trust, and it may be very difficult to repair that therapeutic relationship. And finally, let's talk a little bit about end-of-life care and the adolescent. Of course, Butts and Rich in our chapters, briefly mention the 5 stages of grief, denial, anger, bargaining, depression, and acceptance. And this, that's true for everyone, and it's also true for adolescents. But they point out that adolescents, when they are diagnosed with a serious terminal illness, may undergo some experiences that are worth mentioning. Especially, they may have a propensity to engage in risky behaviors. High-risk behaviors and also a higher risk of suicide. So that's important just to be on the lookout for. But that said, I think we can safely say that in many cases, terminally ill adolescents have a maturity level beyond the normal adolescent. That is, they've been through the ringer. They've had to grow up faster than their friends, and they've had to look at life, in the way that they normally wouldn't have to until they reach adulthood, experiencing the finitude, loss of meaning, the things that we attribute to old age, and those are the things that they have to grapple with, and they become very, very mature very fast. So we can't discount that. So, like I said before, we shouldn't necessarily assume that a child completely lacks decision-making capacity. To the extent that they have autonomy and decision-making capacity, they should be a party to decisions that are being made. And as I noted, this is especially the case for terminally ill kids, because they may in fact have much more maturity than you would expect them to have. All right, now let's look at the other end of the life spectrum, and I think what we will find is that there are a lot of parallels. And just as there are competence and autonomy concerns with kids, of course there are competence and autonomy concerns with the elderly. Just as kids are dependent and vulnerable, so too are the elderly. So many of the lessons that I think we learned in pediatric ethics also apply to elder care, geriatric ethics. a lot of the most important points in providing treatment to the elderly really do center around their moral agency. That is, their capacity to guide their life through their own choices. That's what that refers to. Of course, now we're right back into the heart of it. Decision-making capacity, autonomy and paternalism, vulnerability and dementia. Let's start with decision-making capacity. You know, everyone realizes that there is at least some level of cognitive decline in old age. You know, many elderly folks, you know, seem just as with it as they always have. But by and large, there's at least some level of cognitive decline. It may not, you know, necessarily mean that they are not competent to make decisions. In fact, I will advise that we are very careful not to assume that. But I think we can also assume that there's probably some level of cognitive decline, whether it's memory and in other sorts of related issues. Before we go on, let's remember our rule with regard to decision-making capacity. Remember, we said we judge decision-making capacity or competence on a sliding scale. The more complicated a decision is, the higher level of decision-making capacity someone has to have. A low level of complexity for a decision may not require a high level of decision-making capacity at all. An uncomplicated decision may not require a lot of decisional capacity. So as I say, even someone with some level of dementia could very well have adequate decision-making capacity, you know, depending on the complexity of the decision. You see the little typo there, I apologize. Decision-making capacity. So for an elderly person, let's say they do have some level of cognitive incapacity. There still may be a wide range of decisions that they are capable of making, and it's important that we allow them to make those decisions, especially at a time in their life when they feel that they are being removed from the locus of control in their life, and other people, their children and their doctors, are making all the decisions for them. It's important that, to the extent that they have adequate decision-making capacity, they should be that decision-making capacity should be respected. Now, another thing to keep in mind, especially with those with some degree of dementia, is that decision-making capacity in the elderly may vary even throughout the day. Someone with mild or moderate dementia may be fairly lucid and certainly competent to make decisions about you know, when they want to take their medication, or how they want to, you know, how they would envision what they would prefer, you know, at the end of life. Do they, you know, would they prefer? Do they want to be resuscitated if their heart stops? Do they want to be on feeding tubes if they're no longer capable of swallowing, and or they're unconscious? Do they, you know, or you know, so they, you know, those sorts of decisions may very well be appropriate for them to make when they have decision-making capacity, possibly earlier in the day, but certainly less so later in the day. There are a lot of things that affect decision-making capacity in the elderly. Certainly, for those who suffer from some degree of dementia, it could simply be the time of day. Sometimes it's medication and a range of other things that make an elderly person less capable than they otherwise would be. So, it's always important to kind of look at the medications and see whether that could be the culprit, especially if there's been a very abrupt change in their decisional capacity. And also certainly changes in location, in geographic context, moving from the long-term care facility to the hospital, to rehab, back into long-term care, can be very disorienting. So, so that too may be the source of some confusion and decisional incapacity. How do we, when we talk about having capacity, what would be some possible criteria for determining lack of capacity? Well, certainly the inability to express or communicate a preference would be a strong indicator that the patient or the resident lacks decision-making capacity. And then certainly the inability to understand their situation and the consequences, or to understand relevant information. Those would be serious serious reasons for questioning the decision-making capacity of a resident or an elderly patient. Now these other ones toward the bottom, to give a reason, to give a rational reason, those get a little higher in terms of what we're requiring. Like certainly, I think the inability to give a reason might be a good reason to have concerns about a patient's decision-making capacity. But what about the inability to give a rational reason? I mean, what if someone just doesn't like the cases we've talked about? What if someone just doesn't like this food, doesn't want to eat it? What's your reason? I don't like it. For some kinds of decisions, the mere fact that they have a preference and they've expressed that preference is enough to accommodate that preference. It doesn't take a lot of cognitive capacity to know that that you don't like to sit in that chair, or that you don't like this food, or you don't like this music, or that the TV is annoying, or something like that. I guess this is simply another way of putting the fundamental rule we've already laid out on the table. Just because an elderly patient is not able to offer a complicated risk-benefit analysis or explain a coherent rationale doesn't necessarily mean that they are incompetent with regard to all decisions. That's the trickiest thing. To know that each time a decision needs to be made, the patient's, the resident's decision-making capacity has to be reassessed, at least briefly, to determine whether they have adequate decision-making capacity for this decision. Because it can't be the case that simply because someone did not have capacity to make one decision, that they are therefore disqualified from making any decision ever. Unfortunately, because of the legal dimension of all this, that's often the case. All right. You know, the interplay between autonomy and paternalism is, you know, is such a fact of elder care. You know, and again, I suppose it very much parallels pediatric ethics. You know, we're trying to do a balancing act between respecting the autonomy that's there, but also preventing harm to the patient that may come if the patient is making decisions that aren't competent. So we call this term paternalism. You know, paternalism refers to the disregard or overriding of a patient's choices or wishes for that patient's own good. Recall also that we distinguish between soft paternalism and hard paternalism. Soft paternalism refers to overriding or disregarding the wishes or the choices of a patient when that patient lacks decision-making capacity, when the patient's not autonomous. So remember, we said technically speaking, soft paternalism doesn't necessarily conflict with respect for autonomy. By contrast, hard paternalism refers to overriding or disregarding the choices of a patient for the patient's own good when the patient is competent, when they have adequate decision-making authority. It's just that decision-making capacity, that is. So certainly, you know, in elder care, there's a lot of soft paternalism going on. You know, when a patient doesn't have capacity, we don't want them to bring harm to themselves because of that incapacity. But we don't want to assume that just because someone is old, just because it's difficult to understand what they're saying, just because that there's, you know, their speech is kind of soft, because they are physically debilitated, that they are incompetent to make choices for themselves. Remember, this is a class of patients who have undergone or experienced a lot of loss. They lose their independence, and everything that they do is almost always an attempt to recapture some of that independence. They, you know, they may not be able to drive anymore. They may not be allowed to handle their own finances anymore. They may not be able to decide when they want to eat. They may not be able to decide what they want to eat. All of that locus of control has been taken away from them. And it is justified if it's absolutely necessary to protect them from harm that may result from their own incapacity. But we have to keep in mind, if an elderly person has decision-making capacity, then any competent person is able to has the right to make choices that we think are bad choices. You know, if I want to, you know, eat a meal that the nursing director or the dietitian thinks is risky for me given my difficulty swallowing, well, you know, unless I do not have adequate decision-making capacity, it may very well be that I have the right to make that decision. I may wish to just risk it, and maybe it doesn't make sense to other people, but so long as I know what I'm doing and I understand the consequences of what I'm doing, the mere fact that I'm old and I'm in a wheelchair and other things like that doesn't mean that I don't have the right to make those decisions. let's talk a little bit about vulnerability and dependence as it relates to the elderly. You know, as I said before, the vulnerability and dependence of the elderly is very much analogous to the vulnerability and dependence of kids. But there certainly are some different wrinkles. But we have to admit, we should acknowledge that the elderly are extremely vulnerable in a wide range of dimensions, certainly medically and physically, but socially and financially. You know, they're typically, financially, for example, you know, on a fixed income, and they have someone else taking care of their finances, hoping that that person is doing so with their best interest in mind. That leaves one in a very vulnerable position. They're also socially vulnerable. That is, their physical ailments and cognitive incapacities isolate them from social relationships. It could be something as simple as, you know, a person's arthritic knees keeps him from, you know, going to social activities down in the cafeteria or in one of the common areas, going to the movie night, you know, or the, so something as simple as that, or certainly if you know, someone's difficulty hearing, if you know, hearing loss is a fact of old age. If it's not adequately managed, it can have a serious negative impact on that person's ability to maintain relationships and his desire to maintain social relationships. Also, you know, elderly people are easily coerced. That is, there is considerable worry on their part that that those on whom they depend may no longer provide that support if they don't go along with what the other people want. So rather than anger, rather than anger his son or her son, who's you know, DPOA and you know, making most of the decisions, you know, an elderly person may simply just go along with what you know, what their adult child wants, because they don't want to, you know, they don't want to risk this little support that they're getting. It may be the same for you know, with their caretakers. They don't want, you know, they know that this particular nurse is going to be, you know, bathing them and helping them in other ways, and they don't want to rock the boat. So they don't want to push their wishes too hard for fear of losing the support that they have. So that means that when we are attempting to really maximize their autonomy and their independence to the safest extent possible, we have to be very much aware of the ease with which they are willing to go along with what other people want for them. And if we, you know, it's important to really double check that this is consistent with what they really want. Because as I said, you know, we can't assume that an elderly person, but just by virtue of their physical, you know, debilities, is not competent. And if, you know, finally, just in terms of our general account of ethics in old age, dementia is a reality of old age for a significant number of the elderly. You know, I mean, cognitive decline, as we said, is common even for healthy people who are aging. But you know, dementia, of course, adds a greater level of complication when we are trying to maximize the well-being of these folks while still keeping them safe and treating them with respect. There are different kinds of dementia. We don't need to go into them. I mean, we always think of Alzheimer's, but you know, there are certainly other forms of dementia, even most commonly maybe just kind of a cardiovascular dementia, you know, where there's just not getting enough blood to the brain. As I said before, people with dementia aren't necessarily incompetent. There could very well be decisions that they're capable of making. As I said earlier in the day, tends to be better. Also, with regard to people, especially with the advanced dementia or moderate to advanced dementia, their values and preferences may in fact change. People with Alzheimer's, for instance, you know, they may hate a certain food all their life, but may like it, you know, when they are, you know, in the mid end stages of that disease process. A lot of things that they might have had a distaste for, they might desire, and vice versa. Things that they thought were things that they enjoyed or preferred might become very distasteful to them. A wide range of changes can take place, you know, including even gender preferences and sexual orientation. I mean, those. You know, this is not the time to get into the complexities of all that, but it does create something of an issue, because we know that one of the ways in which we respect the autonomy of someone whose autonomy is diminishing is that we ask ourselves what they would have chosen if they were fully competent here and now, given what we know about who they were as persons, you know, when they had self-government, moral self-government. But there's a certain sense in which sometimes people with dementia, and in particular Alzheimer's disease, in some ways become different people. And I can remember a case I was involved in. There was a woman, and she had advanced dementia, but you know, in her alert years, she told her daughter that she, you know, when she lost her ability to swallow, she did not want to be hand-fed. You know, I guess for reasons you might recognize. Maybe she thought that there's something undignified about that, but when this occurred, when she in fact did lose her capacity to swallow, she loved being hand-fed. I mean, she was clearly hungry and enjoyed the interaction with staff. It clearly was a high point in her day, and it gave her a lot of pleasure. And the daughter was furious that, you know, she came to visit one time, and she saw one of the nurses hand feeding her mother, and really just blew a gasket. And it was a difficult situation. I mean, ultimately we worked it out, saying that we're always going to give some prompts. I mean, if someone is really wants to eat, we'll help them, but we agreed that we certainly weren't going to force feed her mom. But it did give me pause to think about the sense in which in some ways you have a different person there, and I have no tidy way to resolve this for us. You have a different person there, and then the question is, well, do you hold that different person to to have to accord or comply with the preferences of this other person that they were? I don't know. I mean, I know that in the ethics literature there are people who fall on both sides of that question, but it can be a troubling one. And finally, let me just make a few points about long-term care. I appreciate your patience and commitment to hang in there with this lecture. There are a number of ethical issues that come into play in long-term care. Of course, as you would imagine, both of them are kind of autonomy versus paternalism sorts of things, autonomy versus beneficence, balancing safety with independence. But there are other sorts of things too, even that, given that it's a residential situation in common living areas, there are privacy issues. Again, this is a population of folks who've lost so much of their privacy. Not just informational privacy, that information that people now know about them, but also physical privacy. Other people change you, they help you, in the bathroom and bathe you, and so much of the privacy has been given away. So we really have to safeguard whatever we can for those people. Of course, with common living areas, you have all kinds of disputes that you would imagine, not unlike you would encounter, say, in a college dorm. What shows you're going to watch on the TV that's in the common area. Who has their TV too loud? I mean, when people have varying degrees of hearing loss, people turn up the TV very loud, and it's not always accommodating to other residents that don't want to listen to your TV shows and so forth. Other issues, like as I've already mentioned, swallowing difficulties. It's important in long-term care to be very aware of swallowing difficulties, and to when residents might be coughing a lot, or on a variety, you might on a variety of different medications that could dry their mouth, for example. We should be on the lookout for swallowing difficulties. Of course, you could conduct a swallow study. Other things besides medication, acid reflux can contribute to swallowing difficulties. The main thing is that if there's swallowing difficulties, then of course you have aspiration worries, aspiration pneumonia. So if we're trying to live out our commitment to the principle of beneficence and the principle of non-maleficence, preventing harm, principle of beneficence, promoting good, we want to be aware of those things. But of course, as we've even noticed in one of our cases, someone might say, asserting their autonomy, I know I have swallowing difficulties, but I don't want a liquefied meal. I don't want thickened liquids. I don't put that in my coffee. Or, how do we handle those exertions of autonomy? I suggested that, well, I mean, there should be some presumption in favor of accommodating the autonomous wishes of someone. People can make decisions at their own peril. People do that all the time. We differ in how risk averse we're going to be. Sometimes these behaviors, what we might think of as risky behaviors in long-term care are handled with waivers. That is, if someone wants to walk without assistance, or someone wants to eat this meal, oftentimes the facility will produce a waiver, basically to kind of, say, this competent person, waives my responsibility for anything that might occur. I've seen those used in the past. The legal community and the healthcare legal community is kind of divided on those waivers. That is, some say, yeah, some health attorneys say, yeah, you can have a waiver. It's not going to do you any good. Others say, no, waivers do help. That is, but they have to be very specifically worded. I mean, it has to be clear from the waiver that the person's been clearly informed of the risks, and so they have to be very specific and very tailored to the specific concerns. A generic sort of waiver probably will not have much legal strength. But again, why are we talking about waivers? Because we don't want to unnecessarily restrict the independence of autonomy of someone whose autonomy has already been significantly restricted. Other sorts of issues in long-term care, would include like intimacy issues. Certainly there's a married couple that share a room. I mean, when you both have two competent partners in a 50-year marriage, and now they live in their own room in a long-term care facility. I mean, there's little to worry about there. But it is not uncommon for one or both of the residents in a long-term care facility to have some significant dementia. So then the question is, are these intimate encounters consensual, and should we allow someone to be in that sort of situation when she, for instance, has not consented to it? It can be very difficult when one party to that relationship is competent and the other is not. But by and large, if you look at the policies in long-term care facilities, there aren't many that have some, but there are a few. And I think the growing consensus is that if a resident is not able to consent to intimate relations or sexual contact, then it cannot happen. So, okay, I think most of what we talked about in the back half of this audio lecture is going to be very applicable to our discussion of the leisure seeker, and I hope we will have a chance to revisit those points then. Until then, I will post another audio lecture on end-of-life care next week, and I hope you have a nice and safe weekend.